Bariatric Surgery and Diabetes by Dr. Ahmad Bashir.
Thank you, Mrs. Chairman, Mr. Chairman. I would like to start by thanking the European Association and the Arabic Association for the study of diabetes to allow me to present this talk. I come from Jordan. I'm a bariatric surgeon. I'm actually half Egyptian. My mother is Egyptian. Congratulations to Egypt on making it to the World Cup. We're rooting for Egypt next year, definitely. I would like to start by a show of hands. Who refers patients for bariatric surgery? So I have a tough crowd to convince that bariatric surgery actually works. And who considers bariatric surgery safe and effective? What about bariatric surgery is effective but dangerous? The majority of the rest of the crowd. Okay, so we'll go ahead and start. These are my disclosures. I have no financial disclosure. By practice, I'm a majority Roux-en-Y gastric bypass surgeon. I do other surgeries as well as revisions. But what I'm going to tell you is diabetes, as we talk type 2 diabetes and obesity epidemics are on the rise. And the burden, especially in our region, given our financial limitations, is huge. And the International Diabetes Federation already recommend bariatric surgery for type 2 diabetes and obesity, but we're still not implementing those recommendations. Despite having level 1A evidence with randomized controlled trials showing superiority of bariatric surgery with intensive medical treatment, and I stress both, to intensive medical treatment alone on the long term. So we're going to talk a little bit about the burden of diabetes, and it was mentioned earlier, and the new International Diabetes Federation guidelines, some of the randomized controlled trials, and why does bariatric surgery work better on the long run, and the new wonder pill vote for a new medication, and the challenges that we face in our region. So this is the newest International Diabetes Federation Atlas published in 2017, and it shows the difference in our region and all the rest of the world between now and 2045, and the expected rise in diabetes numbers. For us, we lack the financial support. If you see the orange circle, that's the Middle East. Middle East, we can't afford to spend as much as the rest of the world because we are in a huge financial deficit. But a lot of the patients are actually undiagnosed, and we have a high rate of early death due to diabetes in our region. Again, the orange circle. And the prevalence of diabetes in our world is quite high. Egypt is considered one of the highest as well, and it increases with age. And if we can see, the regional preference is approaching 10%, and it's going to go up to 12.1%. And the number of people diagnosed with diabetes in our region will be 82 million. And the number of deaths at 2017 is quite high. And the total amount of money that we spent expected to be 35.5 billion. And that's a huge number given the financial limitations in our part of the world. Egypt is already on the top 10 list as far as the adults with diabetes, a number of adults with diabetes, and it's still going to be on that list in 2045, according to predictions. And it's high on the list as well on undiagnosed diabetes, top 10 countries. And in the International Diabetes Federation guidelines, if a patient with type 2 diabetes comes with obesity, we should recommend bariatric surgery. And we should recommend bariatric surgery as a first primary option for body mass index more than 40. And we should discuss it and recommend it for patients with uncontrolled diabetes, for BMI more than 35, and consider it for uncontrolled diabetes between 30 and 35. And these are the recommendations. And for Asians, it drops down to 7.5 as far as BMI. But why did we come to this conclusion? Why did the International Diabetes Federation come to this conclusion? The different bariatric procedures, the Roux-en-Y gastric bypass is considered the gold standard, and it's been done since 1965, and we have a lot of data on the Roux-en-Y gastric bypass, and majority of the randomized control trials are done on the Roux-en-Y gastric bypass as part of the study. The commonest bariatric procedure nowadays overall is the sleeve gastrectomy, but we're starting to see the long-term effects of sleeve gastrectomy, and some of them are actually not as good as we wished it to be. And the metabolic control over longer periods of time is actually lower. The new kid on the block, which is the single anastomosis gastric bypass, or the mini gastric bypass, as many call it, it's gaining popularity, especially in our region, and we lack long-term studies, especially on diabetes and randomization. The duodenal switch is considered, or the biliopancreatic diversion is considered the scariest procedure. It's scary even for surgeons, but the metabolic effects of biliopancreatic diversion and duodenal switch are the highest, and it's the most potent metabolically. And the one procedure that is losing popularity is the gastric band, although it's still effective in treating obesity and diabetes. So we'll start with the first randomized controlled trial, the gold standard Swedish obesity study. This is where a lot of the obesity science stemmed from Dr. Lance Swanstrom and colleagues in Sweden, and they published their data over the long period of time. And what they studied is they compared two arms, one surgical arm and one control arm, obese, matched in 14 different factors, and they followed those patients up for 20 years. And the size of the population was actually significant, more than 2,000 in both arms. So what they found is a significant weight difference between the patients who did not undergo bariatric surgery, the control group, and the different bariatric surgeries done. And those were done open, those were more complicated procedures back in the day. And despite having more surgical complications then as opposed to now, the overall mortality was reduced by 30% in the bariatric surgery group. The cancer mortality was the most common overall, but the cancer mortality itself was reduced by 39% in the surgical group, and the cardiac mortality was reduced by 56%. And in that study, they found an initial high remission rates of diabetes, and you can see, you can see that the first top graph that reduces with time, actually, the remission rates, the complete remission from diabetes, and that's what we see in the randomized control trials nowadays. But the fascinating part of the study is the ones who did not have diabetes had less prevalence of diabetes in the surgical arm compared to the control arm. And that's actually over a long period of time, and it's reduced by 78%. And the lowest risk group was found in the Roux-en-Y gastric bypass group, so which makes it the most metabolic procedure between the procedures that were studied in the Swedish obesity study. And the fatal and non-fatal cardiovascular events were reduced in surgery as opposed to the control group, and they were reduced significantly. The incidence of atrial fibrillation as well. And cancer was more reduced in women as opposed to men in the Swedish obesity study. And the most fascinating point, the best benefit was found in the patients who had high baseline insulin levels. And other comorbidities like hypertension, obstructive sleep apnea, triglycerides, arthritis, even the ventricular mass was reduced after bariatric surgery. And the best part is the quality of life was improved for patients over a long period of time. And as far as money, the most cost-effective group was actually the ones who had diabetes to begin with. So Sweden is a national insured, no patients pay for their health insurance. So the country actually sees all the financial implications of surgery, and the highest benefit financially was for patients who were diabetics. So the medical community actually started recognizing this epidemic back in 2007, and they met for the first World Congress on International Diabetes Therapies. And they looked at the evidence that was available back then. And it was few retrospective studies. Some of them were prospectively collected. And they concluded that we needed randomized controlled trials to study bariatric surgery and the effect of bariatric surgery on obesity. And this is by far the gold standard of randomized controlled trials for bariatric surgery, and we call it the Stampede trial from Cleveland Clinic, Dr. Phil Schauer and colleagues. And they studied randomized 150 patients between intensive medical treatment, Roux-en-Y gastric bypass, and sleeve gastrectomy, and they had an amazing 90% follow-up at 5 years. And they looked at a primary outcome of hemoglobin A1C less than 6 with or without medications, and the secondary outcomes, complications of diabetes, surgery, effect on comorbidities, and number of medications used. And these are the baseline characteristics. And once they actually started randomization, unfortunately, eight patients refused to continue the study in the medical arm, 1 patient in the sleeve gastrectomy arm, and they eventually ended up with these numbers. And the sickest patients were actually in the Roux-en-Y gastric bypass group as opposed to the rest. And but they were statistically insignificant. And these patients did not represent the regular population. These patients represented the endocrinology clinic population in the Cleveland Clinic. And this is important. And what we saw is a significant decrease in hemoglobin A1C. This laser is not working. In the top left corner between the control group, which is the intermittent dotted lines, and the sleeve gastrectomy and the gastric bypass. And significant reduce in the number of medications. And patients who were not on medications after 5 years were 45% of the gastric bypass group and 25% of the sleeve gastrectomy group, while it was only 2% in the intensive medical treatment group. And in the intensive medical treatment group, they actually had reduced number of medications, which is actually significant. But the increase in weight was seen in the control group. 20% of the patients actually had weight increase. And the weight decrease in the surgical arm was more significant, definitely. And the glycemic control over time was better between different BMIs, even less than 35 and more than 35. And this is the first level 1 evidence in different BMIs, even less than 35. And this is the breakdown of the medications used in that study. And you can see the difference at baseline and a difference at 5 years. It's a busy slide. I wish I had the pointer working. The adverse events, the only mortality in that study was seen actually in the medical therapy group. from a fatal myocardial infarction. One patient in the sleeve gastrectomy group had a stroke. The surgical arm had unique complications, post-operative complications, but they were early on in the first 30 days. Later on, the long-term complications were seen related to the sleeve gastrectomy, as far as reflux was higher in the sleeve gastrectomy as opposed to the control group, and the nutritional outcomes. The fascinating thing is anemia is more common in sleeve gastrectomy, which we sometimes actually advertise as you don't need any vitamins with sleeve gastrectomy. But anemia was more prevalent in the sleeve gastrectomy arm as opposed to the rest of the study. And the quality of life at 3 years was much better in both sleeve gastrectomy and Roux-en-Y gastric bypass. Actually, the gastric bypass had a better quality of life using the 36 questionnaire. And at 5 years, it continued to be better, although the emotional well-being was reduced, especially in the gastric bypass group on the long run. And since the Stampede trial, we had plenty of randomized control trials. They compared gastric banding, Roux-en-Y gastric bypass, biliopancreatic diversion, but a lot of studies over the amount of time. And they were all combined in this meta-analysis by Dr. Muller-Stitch and colleagues, and to look at the effect of bariatric surgery versus the control. And you can see the remission rates. There were very few remissions with intensive medical treatment in any. The glycemic control was more obvious and evident. And the hemoglobin A1C average numbers, mean numbers, you can see in the surgical arm as opposed to the control arm, were significantly better. And they looked at the different types of procedures and the effects of diabetes control, and it was more pronounced in the biliopancreatic diversion and the Roux-en-Y gastric bypass as far as remission, glycemic control, and the change in hemoglobin A1C from baseline medical treatment. So that actually ended up in the Diabetes Surgery Summit in 2016, which combined a lot of international societies, and they looked at recognizing certain bariatric procedures as metabolic procedures. And finally, bariatric surgery made it to the treatment algorithm. And the treatment algorithm, as I mentioned earlier, for BMI more than 30, BMI more than 40, with type 2 diabetes, bariatric surgery should be recommended. For patients who have body mass index of 35 to 240, if they have uncontrolled diabetes, then they should be recommended to have bariatric surgery. If they have controlled, then we can consider bariatric surgery as an option, and that's lacking in our practice. For patients who have body mass index between 30 and 35, if they have uncontrolled diabetes, we should consider bariatric surgery as an option of treatment. But if they're controlled, consider non-surgical treatment and continue medical treatment. What's unique about surgery, it affects a lot of targets. This is a study by Park and colleagues in 2014 looking at the pathophysiology of how Roux-en-Y gastric bypass works. And this image is amazing and fascinating, and I recommend that you actually keep it in your memory till the end of the talk. So it actually affects hormone, increases the incretins and reduces the diabetogenic hormones, decreases hunger, increases energy expenditure, increases beta cell function and insulin sensitivity, and reduces bile acids and changes the gut microbiota, which is very important in the pathophysiology of obesity and its comorbidities, and increases HDL and lower LDL. And it changes the perception of food, reduces fat preference and reduces actually sweet preference. So, and looking at the gut microbia, the diversity is highest between all procedures studied in the gastric bypass group. So why is it that we don't implement these guidelines? And I think it goes back to our view on obesity. The most fascinating study that was published by Dr. Fothergill and colleagues in 2015, actually, the Biggest Loser study. We all know the Biggest Losers and how they're actually supervised by professionals to medically or non-surgically lose weight. And these patients were followed over 6 years. And all of them actually, unfortunately, regained their weight back. And they even measuring resting metabolic rates after regaining the weight did not return back to normal. This actually study changed our perception on obesity. And human body is one fascinating machine that is extremely efficient in conserving energy. And obesity is a chronic disease, and it is a chronic disease, and we only recognized it as a disease in 2014, unfortunately. And this is one new article, actually, by Dr. Lee Kaplan that was published in October 30th about the perceptions and the barriers to effective obesity treatment. And I recommend all of you to read it. And they actually surveyed patients, 3,000 patients, and more than 500 healthcare providers and employers, actually, to get their perception on obesity and what is the best modality of treatment. So only 71% of healthcare providers discussed weight in the past 5 years about patients, and only 55% actually were diagnosed with obesity, and only 24% of healthcare providers scheduled a follow-up visit related to obesity treatment. And why was the discussion not initiated? 52% of healthcare providers said it was due to the lack of time, or there were other important issues to discuss, or I do not believe that patient is motivated to lose weight, and a lot of other reasons. And if you look at this, this summarizes the study. Our patients, and these are the U.S. patients, and 65% of them think obesity is a disease, and 20% of healthcare providers in the U.S. do not think obesity is a disease yet. 80% is a good number, but 20% not recognizing obesity as a disease is an issue. And majority of patients think, they're to blame as far as their obesity. Obesity is not a choice, it's a disease. And we should remove this stigma in 2017 and recognize it as a disease and recognize the effective ways of treating it. And only 62% of healthcare providers looked at weight loss surgery as a good option for treating obesity. And 40% of the U.S. population, as far as patients-wise, do not think, or 60% do not think it's effective treatment. So we need to change these perceptions. So I'll challenge you with this. If we have a magic pill for obesity and diabetes, if I tell you that it increases GLP-1, increases PYY, decreases ghrelin, decreases leptin, and decreases LDL, increases HDL, and decreases bile acids and changes gut microbia, and increases beta cell function and insulin sensitivity, and decreases hunger and increases energy expenditure, and decreases sweet preference and decreases fat preference, would you prescribe that pill? I guess majority of us would, but until that pill comes, Roux-en-Y gastric bypass is considered the safest. So, and for those who consider bariatric surgery is dangerous, I'll tell you what, you know, there are a lot of studies that look at mortality, and you know, bariatric surgery, you'll see the survival rate. It's the top line. The mortality from bariatric surgery is lower than a cholecystectomy. And, you know, these are huge numbers, and this is what we should aim for. It's really not dangerous at all. It's safe and effective, and both of them are safe and effective long-term in treating diabetes and obesity. So, in conclusion, type 2 diabetes is on the rise along with obesity, and the burden in our part of the world is going to be higher. The International Diabetes Federation recommends bariatric surgery with patients with obesity, and we have level 1A evidence, and it's time to actually implement those guidelines nowadays. We have to bypass the obesity stigma, and bariatric surgery is safe. Thank you.
Thank you, Professor Ahmad, for your elegant illustrative talk. I would like to have some questions. The first one about the use of GLP-1 versus different type of surgery, whether sleeve or gastric bypass. Is it the same, or the gastric bypass or sleeve much more?
It depends on the type of bypass, and the you know, the more distal the bypass is. If we bypass a lot of the small intestine, your GLP-1 levels will be higher. The faster the food gets to the Y cells in the ileum, the higher the GLP-1 will be secreted. So in Roux-en-Y gastric bypass, it is higher. It does rise in the sleeve gastrectomy. We don't have long-term studies on GLP-1 and PYY over the long term after metabolic surgery, and it's something to look at.
Yeah. We looked for the advantage only of the bariatric surgery, but we didn't look for the side effect of bariatric surgery. And we will find after a time there is some side effects as regard reflux esophagitis,
yes.
Some of the side effects that puzzle the patient.
Yes, I mentioned in the Stampede trial, the incidence of reflux at 5 years actually was 27% in those patients, and those were only 50 patients. Nowadays, in sleeve gastrectomy per se, we're starting to see not only reflux, but some reports about Barrett's esophagus in patients who did not have reflux or any esophagitis in the past. And that's why long-term outcomes of sleeve gastrectomy are not yet to be defined. That's why I advise patients who want to have sleeve gastrectomy per se to undergo endoscopy annually until we actually answer that question. But you know, anything that we do will have side effects. Any intervention that we do will have side effects. But the benefits are huge for bariatric surgery, especially for patients who have obesity as well.
The third, as regard the beta cell function, you mentioned that there is improvement of the beta cell function.
Yes.
But with the time, there is recurrence of diabetes after 3 or 4 years.
Dr. Mingroni actually in 2017 published his randomized controlled trial looking at BPD, Roux-en-Y gastric bypass versus control. And it's one of the randomized controlled trials that I showed you, and it was included in the meta-analysis. And he showed 43% relapse of diabetes on the long run after 5 years. So we're not talking about remission. You know, as bariatric surgeons, when we started talking about diabetes, we have the cure for diabetes. It's not a cure. It's temporary remission. The chances of remission are higher, and the chances of remission are better the faster we intervene. So if you have a patient with severe diabetes, that patient's remission rate will be much, much lower than a patient who have early diabetes with good beta cell function, a good beta cell mass, and a pancreas that is able to produce insulin. Whereas severe diabetes has lower remission rates with bariatric surgery, and that's definite and very well studied. But the two combined on the long term is much more effective than either alone. And this is where we should work together as bariatric surgeons and endocrinologists on tackling this burden long term.
Lastly, what we found here in Egypt, that there some physicians prefer to do surgery, bariatric surgery, for a patient with body mass index less than 35. Just this for the treatment of diabetes. And I think, I doubt it is something, it's very bad.
It's actually in the International Diabetes Federation, it is considered as part of the treatment, and it should be considered as part of the treatment, especially in patients who have uncontrolled diabetes, if we follow the algorithm. And there are a lot of randomized controlled trial, even in BMI less than 35. But I caution, surgeons, endocrinologists, Dr. Scopinaro, who is the founder of IFSO. He's an amazing scientist. He studied the effects of bariatric surgery on the beta cell mass between patients with body mass index less than 30 and more than 30. And it seems that bariatric surgery and the pathogenesis of type 2 diabetes in the non-obese is different than the patients who have obesity per se. It does not affect the beta cell function as much, and the remission rates and the results are poor in body mass index less than 30. That is well studied as well.
Thank you. Yes, Abir.
Very short questions and very short answers. First, about initial screening of vitamin D level, because there is rising evidence of the presence of hypovitaminosis, D polymorphism in type 2 diabetes. Do you routinely screen for the vitamin D level for patients who are going to have a big operation like RONY?
Yes, we do. We screen for not only vitamin D, but a lot of other vitamins and minerals before surgery, because part of the pathogenesis of diabetes is the malnutrition of the wrong types of food. So patients what we found is actually in our patient population, more than 70% have deficiencies beforehand.
Other issue about the doing this RONY, this large disastrous operation for obese type. Do you have any data supporting or going against? Of course, I think there are data against this, but we find patients in real practice who are obese type 1,
type 1
who are operated upon.
Type 1 is completely different than type 2, and we all know that. But in my patient population, I have one patient, with type 1 diabetes. I can tell you about my anecdotal. We don't have a lot of reports, these are case studies, but it decreases insulin resistance and improves it reduces the number of insulin units used by patients, especially with patients with obesity. But who are non-obese, for treating type 1 obesity, this is...
If I may add, we were actually the first ones to describe the long-term. It was a case series, like 5 cases. We described it 10 years ago in Diabetes Care. In type 1 patients who underwent gastric bypass, Roux-en-Y gastric bypass, because we are also more in favor of this surgery. And basically the results are okay. If you have an obese type 1 patient, achieving good metabolic control is almost impossible in type 1 with obesity, and bariatric surgery is often the only option. So if we have, there are rare cases, but usually young people in their 20s or 30s, so if they accept our suggestion, we do refer them for bariatric surgery. And now there are a number of case series studies. I even saw one meta-analysis or systemic review on type 1 and obesity treated with gastric bypass surgery.
The management difficulty after this, when you administer the insulin, there are management difficulties about the duration of delivering insulin. The transit time will be reduced, of course, in the Roux-en-Y operations. A lot of important issues which will reveal after the operation.
This peri-surgical period is difficult, but otherwise later it really works. So we simply don't treat type 1 diabetes as a contraindication to bariatric surgery. It's rather the opposite. It's what you are stressing out, that we don't really do bariatric surgery in diabetes to make people lose weight, but to achieve better control of diabetes. That's the goal for the treatment.
Finally, the healthy obese. You consider obesity as a disease. There is a rising evidence about the healthy obese, the metabolically healthy obese person who has most of his fat in the subcutaneous region not considered to be an innocent fat. I mean, most of his fat is not the visceral bad guy. Just to comment about it.
I asked this question to one of the scientists, Dr. John Dixon, the paradoxical obesity, the healthy obese. What he said is they haven't shown their metabolic effects yet. Just wait until they show it. So.
The two first questions. One, which patients that you, in good practice, should not be referred to you, and in good practice, you will not operate as a bariatric surgeon? This is one. The second, if you do a bariatric surgery with a success, put the tackling down of the status of the patient and his cognition of his body. This is an issue I wrote an article about. Thank you.
Bariatric surgery is all about health. It's not about, body image. And I always discuss with patients realistic expectations prior to bariatric surgery. A lot of patients come in, they're imagining they're going to be supermodels after. That's not our aim. Our aim is health, first and foremost. And, it should have guidelines, and every practice should have guidelines for, approving to do bariatric surgery and disapproving certain patients. A healthy patient who does not have any metabolic issues, BMI 31, 32, they're not candidates for bariatric surgery, even up to BMI of 35. But patients with comorbidities and body mass index more than 35, I would do bariatric surgery for.
I have a question. Patient experience hypoglycemia.
Reactive hypoglycemia after bariatric surgery, and you see it more often with Roux-en-Y gastric bypass as opposed to other procedures. It is actually, we see it in even sleeve gastrectomy patients. The majority of the patients are actually very well controlled if they change the way they eat, the eating habits, small frequent meals, and that's why I advise patients avoiding high sugar loads, high carbohydrate loads. That's definite, especially in Roux-en-Y gastric bypass. You're gonna tackle as the more you do, the more you'll see this as a symptom. But in our practice, when we looked at that, and even in the Stampede, it's almost the same. Stampede trial mentioned about 10%. In our patient population, 11.1%. The severe hypoglycemia that is uncontrolled with diet modifications, then we use certain medications to control it, like acarbose, or sometimes we use octreotide subcutaneously, and majority of patients respond. The fear of necidioblastosis, or new onset necidioblastosis, and the patients who require pancreatectomies. I worked with Dr. Kelvin Higa, and he is one of the most renowned bariatric surgeons worldwide, and under his belt is more than 12,000 patients, and he has not seen a patient with that required pancreatectomy for hypoglycemia. But it's mentioned in the literature, and that's one of the fears that endocrinologists always ask about in conferences. But myself, I've never seen it before, and hopefully not.
Thank you, Professor. Yeah.
Okay. What are the factors that guide our choice of the surgery type? Is this the surgeon experience only, or the patient factors like eating patterns, cardiovascular risk, and age of the patient?
If you ask this question to a lot of bariatric surgeons, it's probably a surgeon's preference will dictate what he advises for patients. But based on data and the procedures that are studied, bypass operations are better for controlling metabolic diseases like diabetes. Sweet eaters, I say Roux-en-Y gastric bypass as far as sweet preference, because it reduces the sweet taste and the preference for fat through dumping. That's definite. A patient who has reflux, I would not advise sleeve gastrectomy for, never, beforehand. And every bariatric patient should undergo preoperative endoscopy, because you have 10 to 14% who have silent reflux and they don't know it. So every patient should get that study prior to dictate where you go. The new bariatric procedure, single anastomosis or mini gastric bypass, it's quite effective, but the longer term studies, we're seeing more and more bile reflux, more and more even gastroesophageal reflux, acid reflux as well. So those patients, I would not advise, the reflux patients, I would not advise single anastomosis as well.
Yeah. Thank you very much, Professor Ahmad Bashir. Now we will shift the second session. The chairperson, Professor Hisham Habib, Professor Nader Wadia, Professor Omar Saadani.